So welcome to the last session of this workshop, and we appreciate how many people have traveled far to come here, and we appreciate how difficult it is to sit for the length of time we're sitting. This is the last panel, and the formal name for this panel is a policy agenda to improve cancer survivorship care, and this has more vernacularly been known as the solutions panel or the policy panel. And Patty Gans was saying that I was adamant during our planning sessions that we have a solutions panel, and that just shows how gracious she was, because there are a lot of other words she could have used besides adamant. And I do feel strongly that having a panel at the end is important. And I think we've heard a lot during this last day and a half that we have a lot of the evidence, a lot of that generated from previous IOM conferences, NAM conferences, but unfortunately things haven't been implemented to the degree that we'd like them to have been implemented. There are a couple of quotes that I'm going to start with. One is at the front of every NAM report that you see, which I find particularly inspiring. It's from Goethe, which says, "Knowing is not enough, we must apply. Willing is not enough, we must do." And then other quotes from this session from slightly less famous people are, "Just do it. We built it, they didn't come. We've had lots of studies, but we haven't implemented what we have learned. We need marching orders when we leave here." So this last session are the marching orders for folks as the last session. Sort of walk out of here and summarize all the evidence that we've learned and say, what is it that we need to do to actually make this happen? And before we get into some of the questions, and this is more of an interactive session, people won't have long formal presentations, I wanted to give an example of how we can take the evidence that we have and implement it and make it work. And I'm going to talk about my favorite subject, something that I've spent the last 3 years of my life working on, which is the oncology care model. That's what I do Monday through Friday for the last 3 years. Oncology care model is about 195 practices in the United States. It's about 150 or 260,000 unique beneficiaries every year, and it represents about 20% of all of the fee-for-service Medicare oncology care in the United States. And there is a requirement in the oncology care model, and one of those is that you use the 13-point IOM care plan, which Patty and Larissa and a lot of other folks were so instrumental in having. I'm going to take it out of my phone so I can see it here. And one of my favorite conversations was in June of last year, when Larissa got up to the mic and said at the Survivorship conferences, that wasn't really well thought out. We just sort of sat around a table and said, what would we really like to have in a care plan for cancer patients? We didn't ever actually think that anybody was actually going to implement it. That was just pie in the sky. And that was in 2013. 2014, the oncology care model program team started reviewing, doing an environmental scan of the data that's out there. We said, we're going to put the 13-point IOM care plan into our model. So if you want to play in our sandbox, you have to have the 13-point IOM care plan. Included in that IOM care plan is a survivorship plan, prognosis, advanced care directives, out-of-pocket costs, so addressing some of the financial toxicity issues. And then also in our oncology care model, we have depression screening as a requirement for every visit. And what we found, I dodged a lot of rotten fruit as we rolled out the 13-point IOM care plan as a requirement to beneficiaries or to practices. And what we have said, even from some cranky medical oncologists, is, God, it's really made our care better. I was surprised. We've also heard from some oncologists that we didn't realize how depressed our patients were until we started asking about it every day. And right now we have EHRs, people talk about EHRs, we have EHRs that are being designed that have a 13-point care plan within them and that have a survivorship care plan within them. So I would throw that out there as an example of how we can go from evidence to solutions and make what we think is necessary actually work in the real world and roll out to a lot of people. So I put that up there as a positive model. I do have a little bit of bias in that, but I do think that it's something that we can, that is a way that an example of how we can go forward once we already have the evidence. So with that, I'm going to stop my little monologue and ask the speakers to introduce themselves and just spend about 5 minutes or so talking about what they see are some possible solutions to some of the problems we've identified in the last day or so, and then we'll have question and answers. Dr. Barry?